So the way you're going to manage a patient who comes to your unit who is in hyperglycemia. Now, first of all, you're going to do a physical examination. You're going to notice that their skin is very dry. Their skin and mucous membranes are very dry. This person is dehydrated because they have polyuria. Okay, so we find that the patient's skin and mucous membranes are very dry. Patient may be very lethargic, and so you want to make sure that you correct the sugar levels. So the first thing you're going to do after you do the physical examination and obviously the history, you are going to now take a blood sugar test. It could be a random blood sugar test, or it could be a fasting blood sugar test. And obviously these two would be high. And so once they're high, you are going to now start your fluid therapy, especially if there isn't an insulin sliding scale for this patient yet. You start the fluid replacement therapy whilst the insulin sliding scale is being prepared, or if the insulin sliding scale is already available for this patient, you may administer it as well during the time you're administering the fluid. So once you find out that, for example, you get this patient who has a very high blood glucose level, some patients may have up to 30 millimeters of millimoles, okay, of blood glucose level. And so you find that you have to act as fast as possible. You're going to administer about 1 to 3 liters during the first hour when the patient comes. And then you will give a second liter during the second hour. You will give another liter during the next 2 hours. So you're going to also administer 1 liter every 4 hours, depending on the degree of dehydration. This fluid that you're going to give is not going to have any dextrose in it. Do not give 10% or 5%. Do not give that if the blood sugar levels are very high for this patient. You're going to give a fluid that has no sugar, for example, normal saline or Ringer's lactate. However, in patients, especially those of the type 2 diabetes mellitus, you find that they also have hypertension. And so you have to check their blood pressure levels. If their blood pressure is likely to rise, if you give normal saline, then you have to give Ringer's lactate. You have to be very cautious about what fluid you're giving this patient. Okay, so now when it comes to type 2 diabetes mellitus, you are also going to give other pharmacological agents. So these pharmacological agents will be hypoglycemic agents that will help to reduce the blood sugar levels. So some of the hypoglycemic agents include, one group are the biguamides, and these reduce insulin resistance and they promote insulin sensitivity. And an example of a biguanide is metformin. You're going to give this depending on the prescription at 250 or 500 milligrams TDS, okay? And then you can also give sulfonylureas, which increase production of insulin and action. And one example of a sulfonylurea is glibenclamide. The common name for glibenclamide is Daranil, and you're going to give this this drug at 5 milligrams daily, okay? You can give glimepiride 1 milligram or 2 milligram or 4 milligram. These are the presentations of these tablets. So these are some of the examples of sulfonylureas. The most common one, I think, in Zambia should be Dawanil. Okay. So now we have complications of diabetes mellitus. It's very important for us to know what are the possible complications that a patient who is not managed well, what possible complications can they end up having? And these complications are very, very serious, and some of them are actually life-threatening. Okay, so one, you find that there will be damage to blood vessels because of the too much sugar in their bloodstream. And this will lead to what is known as microangiopathy. Now, what microangiopathy can cause different problems in different organs, because it means that the blood supply to those particular organs is impaired, because those micro blood vessels, micro arteries, they may not be big enough to allow for good elasticity, So you find that if you do not pay attention, the patient will develop microangiopathy, which may cause problems in any organ. And some of the organs may be very, very, very cardinal organs. So the first complication that may happen would be diabetic retinopathy, which is due to the growth of poor quality blood vessels in the retina, okay? And this will lead to vision loss. The patient may end up being blind. The second complication could be diabetic foot. This is an ulcer which can happen. It is called diabetic foot because it normally happens on the feet, okay? But it can happen on the hands where there is no blood flow. The blood flow is impaired because the blood vessels that supply that particular area are impaired. So you find that this patient is going to go into having a very severe wound that does not heal. These severe wounds can be so severe that at some point the patient may have to go for amputation, because for one, wounds in a diabetic patient do not heal quickly because of the sugar levels that are too high in the blood. And sugar is the one that facilitates the growth of microorganisms. And so you find that you may be trying to treat this patient, and so the patient's wound is not healing. Not only that, the poor blood supply to this particular area may also mean that there aren't enough nutrients coming to the area to come and promote healing. Even the drugs that you may be giving orally or IV may not reach the area because blood supply to that particular place where there is that wound is not adequate. The third complication would be diabetic neuropathy. This is abnormal and decreased sensation. Now, this usually happens in the glove and stocking distribution, meaning in the hands and feet. So it starts with the feet, potentially in other nerves. That can happen in any other nerve. Later, you find that even the hands and fingers are involved. And then the other complication could be diabetic myotrophy, where the muscles are weakened. Now, this weakening of the muscles is usually due to the neuropathy, because the nerves that are going to these muscles are weakened because the blood that is supplying them is too high in sugar. The fifth complication could be diabetic nephropathy. This is damage to the kidneys. So you find that the nephrons of the kidneys also get damaged because there is too much sugar, and that sugar starts settling on the nephron, on the glomerulus. So in the glomeruli, you find the sugar molecules are settling there, and with time, there is going to be damage to this glomeruli. And once there is damage to this glomeruli, there is going to be nephropathy, which will later lead to kidney failure. And so this patient may end up with kidney failure, and if this kidney failure is not well managed, the patient's will end up in chronic kidney failure, which may not be able to be resolved. Okay. The other complication could be diabetic cardiomyopathy. This is damage to heart muscles. Now, this leads to dysfunction, and eventually the patient will go into heart failure. So these are very, very severe complications, and they need for us to pay attention to this patient in order for us to know how to care for them. Now, some of the differences between hyperglycemia and hypoglycemia in diabetic patients. Remember, a diabetic patient is prone to both hyperglycemia and hypoglycemia. So you find that you need to know the difference between how this patient is going to present. First of all, you're going to get a history when the patient comes in. The patient may be in a coma, but you get a history from this patient's relative or whoever has brought them. What have they what has the patient skipped? Is it a meal or is it an insulin dose? So if the patient skips an insulin dose, it means that the patient may go into hyperglycemia. Or if the patient had a meal that too high in carbohydrates, the patient may go in hyperglycemia. If, on the other hand, the patient, okay, has skipped a meal, it means that the patient's blood has no sugar at all, and so the patient is in hypoglycemia. When you look at the patient, a patient who is in hyperglycemia will be dehydrated, and therefore their skin and mucous membranes will be dry. On the other hand, the patient who is in hypoglycemia will be sweating, and so their skin will look moist. When you do a urinalysis, you find that the patient will have glycosuria, and in hypoglycemia, the patient will not have any glycosuria. The hyperglycemia is treated with a shot of insulin, whilst hypoglycemia is treated by giving some glucose. So you can give the patient IV glucose depending on the levels of the levels of the glucose in their blood. Once you check, you can give a 50% dextrose shot, or you can commence 5 or 10% dextrose depending on the prescription, as well as depending on the levels of glucose in their blood. In hyperglycemia, the patient will present with Kussmaul's respirations. Remember, this patient is in diabetes, in diabetic ketoacidosis. They can be in diabetic ketoacidosis, or the patient may just be in acidosis. So you find that they will be trying to pull in as much oxygen and push out as much carbon dioxide as possible. And so they find that this patient will have Kussmaul's respirations. In hypoglycemia, on the other hand, patient will not have Kussmaul's respiration. Hyperglycemia is gradual when starting, meaning it has a gradual onset, whilst hypoglycemia has sudden beginning of symptoms. The patient will just suddenly collapse, okay? The patient will just suddenly faint, and so you find that this patient has all these issues. So that is the treatment for diabetes mellitus.